left off describing the various types of receptors in the autonomic nervous system. We had already talked about the cholinergic receptors, and we differentiated between the fast and the slow. So the fast is the ionotropic or nicotinic, and then the slow is the metabotropic or the muscarinic. And so we began looking at the adrenergic receptor. So these are different in that they do not bind acetylcholine. Instead, they bind norepinephrine, epinephrine, or sometimes dopamine. And what we began looking at is how they differ. So there are many subclasses of these adrenergic receptors in terms of their location. So what types of tissues do we see them on? In terms of their effect on the tissue, whether they are excitatory, that is, whether they stimulate the tissues, or they are inhibitory and they sort of decrease the response at tissue level. And then also their affinity. So because they combine norepinephrine, epinephrine, they usually have sometimes an affinity or affinity for one over the other. So we'll talk about that with respect to all of the various types of adrenergic receptors. So thinking about the alpha adrenergic receptors, these are going to be the most abundant throughout the body. They are usually found on different types of effector organs, and we'll talk about how they differ between alpha 1 and alpha 2. They are usually excitatory, and excitatory here means that they stimulate the tissue. A good example is contraction versus dilation, because a lot of alpha adrenergic receptors are found on the smooth muscle that's inside blood vessels. They can either constrict or contract those blood vessels, or they can relax those blood vessels. So this is what we mean by excitatory versus inhibitory. How are they affecting the tissues that they are found on when norepinephrine or epinephrine does bind to that receptor? And then the affinity can vary, usually greater for norepinephrine than for epinephrine. Beta receptors on a whole, they all activate the same second messenger. So cyclic AMP is their second messenger. What they do to that second messenger is going to vary. Whether or not they cause an increase or decrease is going to vary depending on if it's beta 1, beta 2, beta 3. But cyclic AMP is the same second messenger for all three types. And then their affinities can vary as well. So there can be some that are even affinity or some that prefer one over the other. So let's look at that. So beta 1 is on cardiac muscle and the kidneys. It's going to usually be excitatory to those tissues. So that is to stimulate or increase cardiac muscle contractions, or to result in increased kidney function as well. So excitatory to both of those types of tissues. It has an equal affinity or an even affinity. It doesn't have a preference between norepinephrine or epinephrine as compared to beta 2. So beta 2 is usually on blood vessels and the smooth muscle in some types of other organs, like the lungs, for example. It is usually inhibitory. Inhibitory means that it's going to decrease that tissue response. An example in the lungs is that beta 2 will actually cause dilation of the bronchioles. So instead of constriction, which is the excitatory response, beta 2 dilates the bronchioles, which is going to be important in terms of bringing more oxygen into the lungs. So while we think about that action on the tissue as being inhibitory, it's still in alignment with the overall sympathetic response. So if you're fighting or fleeing or running from a threat, you want more oxygen to get into your lungs. But that specific tissue, the type of response that's needed for that would be an inhibitory one. Its affinity is for epinephrine over norepinephrine. So unlike the alpha receptors, which prefer norepinephrine, beta 2 specifically prefers epinephrine instead. And then beta 3 is on adipose tissue mostly. It's also excitatory to those tissues, and then it has an even affinity just like beta 1. Okay, now we're going to go and look at the actual signal transduction mechanism. So what are the steps that are involved from the time that the neurotransmitter or hormone, in this case, binds to the receptor, and then we have the response on the tissues. So what are the signaling transduction mechanisms that help to bring about that response? And because alpha receptors have two different mechanisms, so alpha 1 has an entirely different mechanism than alpha 2. So we're going to talk about those two mechanisms separately. And then for the most part, all beta receptors have the same second messenger and slightly different response to that second messenger. We'll talk about those separately as well. Let's begin by thinking about the alpha 1 receptors. So alpha 1 receptors are, as we mentioned, they have a higher affinity for norepinephrine. So we're going to more see norepinephrine binding to these receptors. They are going to be coupled to a G-stimulatory protein. So the small s here means that when the neurotransmitter binds, this actually stimulates the G protein. The alpha subunit moves downstream in the membrane and binds to an enzyme here. This is called an amplifier enzyme. The amplifier enzyme gets activated and it's going to make that second messenger. So in this case, the amplifier enzyme is phospholipase C. And lipase here means that this is going to cleave something, right? It's going to cut something. And that is exactly what happens. Phospholipase C is going to cleave PIP2. PIP2 is phosphatidylinositol bisphosphate, right? So that can be a mouthful, but it's PIP2 that gets cleaved into two smaller subunits. And these smaller subunits are our second messengers. So PIP2 gets cleaved into IP3 and DAG. DAG stands for diacylglycerol, and IP3 stands for inositol triphosphate. So those are the smaller components that actually go into the cell and help to bring about the cellular response, otherwise known as the second messengers. And what they do is they basically can either activate another enzyme in the cell, and this is going to be tissue specific, so it's not important to really memorize the specific enzyme here, or it can result in the release of calcium. Calcium is typically stored here in the endoplasmic reticulum, and these second messengers, especially DAG, can go into the cell, result in calcium release, and that can generate the response. So by way of the second messengers going into the cell and having some type of intracellular response, that is what helps to bring about the specific tissue response. So just to walk through those steps here. So norepinephrine binds, the G-stimulatory protein has the alpha subunit dissociate off. It is going to bind to phospholipase C, which is activated in this at this time. Now it's going to cleave phosphatidylinositol 2 or bisphosphate 2 into two smaller parts, which are IP3 and DAG. IP3 and DAG can both enter the cell and bring about that cellular response, either by activating an enzyme in the cell or by resulting in calcium release. And then we have our cellular response. So that is specific to alpha 1 receptors. Okay. Let's think about alpha 2 and beta receptors. And this image really tries to simplify this, but I want to really explain that while we show alpha 2 and beta on the same cell membrane, really in a simplified way, we want to recognize that these are actually found in different types of tissues entirely. So for simplicity's sake, we're going to talk about them here together and their different mechanisms, but understand that they're on different locations on the body. They're not going to be found necessarily on the same types of, or predominantly on the same types of tissues. Let's start with alpha 2. So alpha 2 will bind to norepinephrine or epinephrine. In this case, it is coupled to a G inhibitory protein. So when that binding happens, this is going to inhibit this whole process. So the inhibition means that the alpha subunit inactivates adenylate cyclase. So the negative sign here means that this is inactivated in this case. And what that results in is cyclic AMP, a decrease in cyclic AMP, and that is the cellular response. So the blocking of or inactivation of adenylyl cyclase is what helps to bring about the drop in second messenger, and that is what generates the tissue response for alpha-2 receptors. Now, when we think about the beta receptors, they are also acting on cyclic AMP, but their response is going to be different. So they are coupled to a G stimulatory protein, and that will have the alpha subunit dissociate off, and that will actually activate adenylyl cyclase. And by activating adenylyl cyclase, that is going to result in cyclic AMP increase. Then we activate an enzyme in the cell, protein kinase being an example here, which will phosphorylate some protein in the cell and bring about that response. So while both the alpha-2 receptors and the beta receptors, all three, beta 1, 2, and 3, are using the same second messenger, their action on that second messenger is different. Alpha-2 is going to inhibit, and beta receptors are going to activate or excite. So let's kind of describe that here again. So alpha-2 norepinephrine binds, the G inhibitory protein is activated or inhibited. Alpha subunit is blocked, or alpha subunit inhibits adenylyl cyclase. So this subunit still dissociates off. By the binding, that subunit is still triggered off. Because it's an inhibitory G protein, it ends up inhibiting adenylyl cyclase. For beta receptors, epinephrine or norepinephrine binds. The G protein here is a stimulatory G protein. So when its alpha subunit moves off, that activates the amplifier enzyme, which is adenylyl cyclase. That actually creates the second messenger instead of blocking the second messenger, which is what the alpha-2 receptor does. Now we have protein kinase, and then we have phosphorylation of some protein in the cell. Again, this can be tissue specific. And then we have the cellular response. Okay. So really important to think that the same second messenger is involved, but just one is inhibited and the other is activated. Now, here's a nice summary table to look at the effector tissue. So where are the locations that we see these types of tissues? Alpha-1 receptors, both alpha-1 and alpha-2 are usually on blood vessels. Alpha-1 is going to be mostly on vascular smooth muscle. So this is the majority of where we see alpha-1. Alpha-2 will be on some vascular smooth muscle as well, but mostly in other areas. A little bit on adipose, a little bit in the central nervous system, some on platelets, on the adrenergic nerve terminals. And the difference with alpha-1 and alpha-2 is that alpha-2, as we mentioned, inhibits its second messenger. Alpha-1 had a different amplifier enzyme and second messenger altogether. So alpha-1 is sort of different in that way. Both of them will end up resulting in excitatory responses on the tissue. So don't confuse the action on the second messenger with the action on the tissue level. So in the case of alpha-2, when we have inhibition of cyclic AMP, that actually helps bring about the excitatory response on these specific types of blood vessels. If we look at the beta receptors, they are found in different areas as well. So the beta 1 on the central nervous system, cardiac muscle, and the kidneys. Beta 1, we said, has an equal affinity, so it doesn't have a preference. It will activate its second messenger, and then that becomes excitatory on the tissues. In other words, increasing cardiac muscle contraction, etc. Beta 2 is on some blood vessels, so very small amount of blood vessels as well. The respiratory tract, so the lungs, and then the uterus is another example of where we see beta 2. Beta 2 prefers epinephrine, and then it is activating its second messenger CYP, but that ends up being inhibitory to the tissue level. In the example that we looked at with the respiratory tract is the activation of cyclic AMP results in the dilation of the bronchioles, which is encouraging more oxygen flow to the lungs. In beta 3, this is usually on adipose. Norepinephrine is the preference. It is activating cyclic AMP, and that brings about an excitatory response. On this summary table, this one is less important than the previous table in terms of study purposes, but this one is just to give some examples of how we can use certain drugs and pharmacological agents to activate or block some of these adrenergic responses. So many of the common medications that we see actually target some of these receptors. An example would be if we think about isoproterenol. This is actually used in asthmatic patients, folks who have asthma, which is usually the constriction or contraction of the bronchioles, right? And so with the understanding that beta-2 receptors usually bring about bronchodilation, we can give these patients a drug that targets these receptors in an agonist type of way. In other words, it's going to stimulate this response and help to dilate the bronchioles, which can give relief to patients with asthma. And an opposite function of that would be beta antagonist. So atenolol is one of the blood pressure medications that we use. It actually blocks beta-1 receptors and treats hypertension. And the reason is beta-1 receptors are usually excitatory. So if we activate them, they will increase ventricular contraction. And if we have patients with high blood pressure, we kind of want to block or blunt that response. So blocking these beta-1 receptors actually decreases the cardiac contraction and can decrease blood pressure in these patients. So thinking about just taking advantage of some of these receptor responses, either by antagonizing them or agonizing them, we can help to bring about the desired effect that can be therapeutic in some of these diseases. Okay. Let's think about the neuroeffector junction. So the way that the synapse between the efferent neurons and the effector tissues in the autonomic nervous system, how does that vary from, say, a regular neuron-to-neuron synapse between two neurons, right? Two traditional neurons. So this is different in that it's between a postganglionic neuron, in other words, an efferent neuron that's coming from the central nervous system. It has neurotransmitter that is stored in the axon swellings, and these are called varicosities. It's going to release this in response to the action potential arriving at the varicosity. So this is not going to be a discrete axon terminal the way that we see in a neuron-to-neuron synapse. Instead, it's just going to be a swelling at the end of the neuron, and then that is in close proximity to the tissue that's being affected. So this can be the heart tissue, this can be smooth muscle on blood vessels, this can be uterine tissue, anywhere that we have these effector organs, and that is where these varicosities come in close proximity so that they can release these synaptic vesicles and the neurotransmitter can bind to the receptors on these tissues. So if we look at the close-up version of that, here's what the varicosity looks like. Here is the synaptic vesicle inside that dilation or the swelling. And then inside the vesicle, we have the neurotransmitter in question. So depending on if this is a postganglionic neuron, the sympathetic side, it would contain norepinephrine or epinephrine. If it is a postganglionic neuron on the parasympathetic side, it would contain acetylcholine. We also want to remind ourselves of the types of voltage-gated channels that are important in the synaptic response. So voltage-gated sodium and calcium channels are on the axon, so this portion of the neuron. And then voltage-gated calcium channels are on the varicosity itself that are going to help with exocytosis that will help this neurotransmitter cross the junction. Okay. So let's look at the steps of this type of response. And it's very similar to the steps that we illustrated before when we talked about the synapse, but there are just a few differences. So the action potential arrives at the varicosity. Voltage-gated calcium channels open up. Calcium rushes into the varicosity. This triggers exocytosis, and the vesicle moves closer to the membrane and then dumps its contents into the neuroeffector junction. The neurotransmitter can cross the cleft. It can bind to the receptor on the tissue. So here's the effector cell, which is on the tissue of the effector organ. And then it's going to bring about that response by way of the mechanisms that we talked about earlier. So depending on if this is an alpha 1 or alpha 2, the type of amplifier enzyme will differ. It will either be phospholipase C or adenylate cyclase, and it will either activate or inhibit its second messenger and then bring about that response. Now, because this is specific to the parasympathetic system, we're not thinking about norepinephrine here. We're thinking about acetylcholine crossing the cleft, binding to a muscarinic receptor. Remember, at the neuroeffector junction on the parasympathetic side, it's not a nicotinic receptor here, it's a muscarinic receptor, and then acetylcholine can bind, and that will result in the cellular response. Now, the acetylcholinesterase is here to degrade the extra neurotransmitter, or we can have reuptake of that extra neurotransmitter and recycling, as we have described before. We can also have the neurotransmitter simply diffuse away as well. On the sympathetic side, things differ a little bit. So the receptor is an adrenergic receptor. The amplifier enzyme, we said, can again vary depending on the specific type of receptor and tissue, specific tissue. The neurotransmitter that's packaged in the vesicle here is now norepinephrine. We also want to think about the location where norepinephrine is made. So they included the mitochondria in this just to show that neurotransmitter norepinephrine is actually made by a different mechanism. It's made by monoamine oxidase, which is a specific type of enzyme in the mitochondrion that makes the norepinephrine. That will cross the junction and then bind to its receptor and then bring about that response on the effector cell. Now, acetylcholinesterase is not going to be present here because acetylcholinesterase only degrades acetylcholine. In this case, norepinephrine usually is reuptaken, recycled, including the help of monoamine oxidase, and then repackaged to make new vesicles. So do not think about acetylcholinesterase as degrading norepinephrine. It's really only for